Okay, good afternoon all, and thank you so much for joining Women's Health at in the Southeast at our webinar covering an introduction to reproductive coercion and primary prevention. Today we'll be joined by a panel of key knowledge experts on reproductive coercion through an intersectional gendered lens. But before we begin, I'd like to acknowledge that we're meeting on unceded Aboriginal land, the land of the Wurundjeri and Bunurong peoples of the Kulin Nations, and I pay my respects to elders past and present, and would like to extend a particularly warm welcome to any Aboriginal and Torres Strait Islander people who are joining us here today, and express my hope for reconciliation and treaty. Today's webinar will be facilitated by myself. My name is Laura Riccardi. I'm the Sexual and Reproductive Health Lead at Women's Health in the Southeast, and my colleague today, Danny McCaffrey, who is the lead for the primary prevention of violence against women. We're very fortunate to have a number of key knowledge experts addressing us today, including Associate Professor Laura Tarzia from the University of Melbourne, who will be providing an overview of reproductive coercion within the current research and evidence frameworks and furnishing our understanding of the key drivers of sexual violence against women, including reproductive coercion, and how these relate to our general frameworks of understanding gendered violence more broadly, including our WHISE framework. We'll also be joined by Desiree Legrape, a PhD candidate at La Trobe University, who will be examining different forms of reproductive coercion, including structural or institutional coercion, so not only intimate partner violence, but also within the medical and criminal justice systems, and providing us with an overview of her current research on screening for reproductive coercion in clinical and community settings. We'll also be joined by Helen Freris, who's the Program Manager at Women with Disabilities Victoria, who will be providing us with a critical analysis of the experiences of institutional and interpersonal reproductive coercion experienced by women living with disabilities as a result of both ableism and sexism, including sterilisation as a form of reproductive coercion that's disproportionately experienced by women and people living with disabilities. Finally, we'll be joined by Rosie Arrow-Lees, the Research, Advocacy and Policy Team Leader at the Multicultural Centre for Women's Health, who'll be providing us with an analysis of the experiences of institutional and interpersonal reproductive coercion as experienced by women and people from migrant and refugee backgrounds as a result of racism and sexism, and examining the impact of government policy, including Medicare exclusions, and the experience of international students and those on precarious visas. Before we launch into the presentations from our knowledge experts, we would like to provide a brief introduction of Women's Health in the Southeast, or WHISE, and our two portfolios that are hosting today's webinar. Women's Health in the Southeast is one of 12 Victorian women's health services working across the state of Victoria with partners and stakeholders, including those in state and local government, community health organisations, the family violence sector, other youth, social and community services within a primary prevention framework and an intersectional feminist ethos to advance gender equity, prevent violence against women, improve women's sexual and reproductive health, and more recently, improve mental well-being. As the Sexual and Reproductive Health Lead at WHISE, I oversee the implementation of our 4-year regional strategy and network for sexual and reproductive health, Good Health Down South. And our key strategic priorities in this portfolio are to integrate and prioritise sexual and reproductive health within other health and wellbeing priorities at a state and local government level and within organisations operating in the Southern Metropolitan Region, enhance equitable access to critical sexual and reproductive health services, and increase the health literacy of community and practitioners to ensure that everyone is able to achieve optimal sexual and reproductive health rights. I will now pass briefly to my colleague, Danny McCaffrey, to introduce her portfolio.
Hi everyone, I'm Danielle McCaffrey and I'm the Prevention of Violence Against Women lead at Women's Health at Southeast. And I bring together the regional strategy called Promoting Respect and Equity Together, which is a network for the primary prevention of violence against women, led by WHISE and supported by our partners and stakeholders. Our strategic priorities are making prevention of violence against women and gender equality everyone's business, organisational and strengthening and leadership, building workforce capacity, knowledge brokering, and collaboration and networking. Thanks so much. And so I'll hand back to you, Laura.
Not a problem. Thank you very much, Danny. I'd now like to introduce our first presenter, Associate Professor Laura Tarzia from the University of Melbourne. Laura is an Associate Professor and Principal Research Fellow in the Department of General Practice at the University of Melbourne. She co-leads the Sexual Abuse and Family Violence Program and leads a stream of research focused on sexual and reproductive violence. Laura is a leading scholar in the field of reproductive coercion and abuse and is undertaking novel work around defining and responding to this hidden form of violence. She has a strong commitment to highlighting the voices of victim survivors to increase understanding and develop tailored responses. I'll now pass over to Laura.
Thank you, other Laura. I will just share my screen. Okay, hopefully that's all looking good. Thanks very much for the introduction and the opportunity to speak today. I would also like to acknowledge the traditional owners of the lands that we're meeting on. For me, it's also the Wurundjeri people, and pay respects to elders past and present. I'd also like to acknowledge any victim survivors who might be tuning in today, and I hope that all of the presentations today reflect your experiences and your strength and resilience. So reproductive coercion and abuse is a fairly new sort of, it's not a new phenomenon, but it's been newly spoken about in research. And we're still at the stage where there's a whole lot of different terms that get used. And I'll explain a bit why I personally use reproductive coercion and abuse and why I tack that onto the end. But you might have heard it talked about as forced pregnancy, you know, coerced reproductive, stealthing, forced abortion, all these sorts of terms. And we're talking about mostly the same thing, which is really pregnancy promoting behavior. So behaviors like forcing somebody to get pregnant, forcing them to continue a pregnancy that they don't want to continue, pregnancy preventing behavior, so doing the opposite of that, forcing someone to have a termination of a pregnancy that they wanted to keep. I feel very strongly that there needs to be an intentional or deliberate nature to that behavior. So I'm going to talk a bit more about that as well. But basically, there's other things that might have a reproductive outcome, but which are that's sort of incidental. So for example, sexual violence, rape, you know, it might cause somebody to be pregnant, but the intention of the perpetrator was not necessarily to do that. So when I speak about reproductive coercion and abuse, I'm trying to be, you know, put that boundary around that it is intentional behavior. Other things are also equally problematic, but they have another label, which might be sexual violence, might be intimate partner violence, and so forth. I'm going to focus today on interpersonal reproductive coercion and abuse, and this is still an ongoing debate amongst those of us who work in this space as researchers about exactly how we define reproductive coercion and abuse, and you know, how those sorts of structural issues, and I won't talk to this too much because I think Desiree and others are going to cover it as well, but structural sort of factors that influence somebody's reproductive autonomy when those become reproductive coercion and abuse, and when they are something else. They can be facilitators of it. So I guess the jury's still out in terms of there hasn't been enough research to be able to look at people's lived experience and where it's similar and where it's different when it occurs in an interpersonal context, so like an intimate partner relationship or a family, versus things that happen, in health systems, with government policies. Certainly we've seen a lot recently with Roe versus Wade in the States, that some of these things that are happening at the structural level can really impact people in terms of fearfulness and control. And so it's an emerging space, and we need to do a lot more work in this area to understand it all properly. So interpersonal reproductive coercion and abuse is primarily perpetrated against women by their male partners or family members. And I do want to acknowledge that not all people with female reproductive organs identify as women, but just for the ease of communication, to avoid having to say, a more lengthy term, I'm just going to talk about women, but I do also mean people with female reproductive organs who don't identify that way. So it's usually their male partners, it's usually other family members. We do know from the literature that it's associated pretty consistently with physical violence and sexual violence. So those are things that pop up pretty commonly in studies that people have done. And we also know that it can lead to poor mental health outcomes. So things like anxiety, depression, post-traumatic stress, and so forth. And also other poor health outcomes. So the obvious one being unintended pregnancies, but also sexually transmitted infections and stuff like that. So there's not a really robust body of literature in that space, but what is there does suggest that it's got a lot of harmful impacts on people's health and well-being. In terms of how common it is, again, we find for a whole lot of reasons the data is pretty dodgy, unfortunately, but hopefully that's something, as more and more people start working in this space, we're going to see that remedied with more robust, prevalence studies. So data from America suggests anywhere between 8% and 30% prevalence in clinical settings. And in community settings, there's been fewer studies, but, around 11% has come up in some research over there. In Australia, again, we're only just starting to sort of recognise and include reproductive coercion and abuse in work that's about, family and intimate partner violence or sexual violence. There hasn't been very many studies that have looked at this, but more and more people are starting to get interested in this and in trying to develop, a good, robust prevalence survey that we can measure this properly. So one study from the family planning context in New South Wales only found 2.3% it was a study about routine screening. I did a study in general practice a few years ago that was looking at sexual violence more broadly, and we asked some questions about reproductive coercion and abuse, and the prevalence was about 10%. A recent study I was involved with where we looked at routine counselling data from a pregnancy counselling service nationally found it was about 15% was how common it was there, with roughly equal numbers reporting pregnancy promoting and pregnancy preventing. And then another recent study, which was amongst a sample of survivors of IPV, intimate partner violence, about 30% of those people reported some type of reproductive coercion and abuse. So really varied estimates there, really. In terms of risk factors, the data is inconsistent and very, very unreliable. And I'm going to talk a little bit about why this is. Because it's sort of an ongoing problem with the evidence base in this area. So a few years ago, I published this paper, which I can provide the link for anyone that's interested. It is open access. And I was sort of reflecting on reproductive coercion and abuse and all the research that had been done and why there were so many problems with, measurement and understanding this topic. And I identified a few ongoing problems. So one was around terminology, and previously people were just referring to it as reproductive coercion, but what I found was that actually people were getting very confused by that. I mean, in the domestic and family violence sector, everyone's familiar with coercive control, so there it wasn't such an issue, but outside of that space, in talking to health practitioners and other people, coercion, just talking about coercion was very suggestive of just anything that was sort of influencing someone's decision. And so I was finding that people were talking about reproductive coercion, but actually talking about things that were not really the same as, you know, what you would typically think of as abusive behavior. And also by talking about coercion, it was confusing to people who were encountering this issue where perpetrators were doing really sort of severe physical or sexual violence, and people saying, well, that's more than coercion, you know, that's abusive. And so I've kind of been advocating that we shift to a terminology that is clearer about what sorts of behaviours we mean, and it doesn't confuse people by thinking that anything that's remotely influencing should be included. So that's why I have tacked the abuse on the end. It's a little bit clumsy and long, I recognise that. But so far, I haven't come up with a better alternative, and I haven't heard anyone else suggest anything that's better. So for now, I'm just sticking with it. It does seem to be catching on a little bit, but I'm still of two minds about whether this is where we want to go. But it's better than reproductive coercion, I think. It is clearer than that. So that was one issue. And then there was this issue around context where, as I mentioned before, people were including this whole raft of behaviours and saying it was reproductive coercion because the outcome was an unintended pregnancy. But I think we have to be very careful, and this has implications for measurement and why a lot of the data around prevalence and risk factors is so bad, because people are not measuring the same thing. Some people are measuring, for example, you know, things like stealthing as an example. And what I found in some of my research is that stealthing for pleasure, so removing a condom without consent, that is, because you just don't like condoms, is very different to taking off the condom because you want to get someone pregnant. And what I found by speaking to different groups of victim survivors was that the women who'd experienced stealthing for pleasure or for other reasons, just because, you know, the guy was not a nice person, they experienced that as disrespect and selfishness, and it was often in the context of a casual or short-term relationship. And, you know, that was much more aligned with sexual violence and those feelings of like, I've been violated, somebody's, you know, disrespected my consent, and, you know, that sort of experience. But then when it was deliberately to get someone pregnant, it was a vastly different experience. Often that was in the context of a more long-term relationship. Sometimes it was a relationship where there was other types of abusive behaviours happening. Women felt very controlled by that. It was like somebody, you know, really trying to override their decisions about their own body. It was a quite different experience for them. So that's just a working example of why I think it's important that we clarify the intent. And of course, sometimes women have no idea what the intent of the perpetrator is, and we can't know that. But often they do have a pretty good sense of why this behaviour has been done to them. You know, it's often in the context of a lot of other stuff going on in the relationship. So yeah, not always, but often I think they can take a good guess. So in summary, for me, reproductive coercion and abuse is very much about an intentional behaviour to get someone pregnant or prevent them from being pregnant. And to me, fear and or control are really central. So we're not talking about things that are accidentally getting someone pregnant. It's like, you know, that's the plan. There's either fear of really negative consequences, either fear of for their personal safety, or psychological abuse. You know, I'm going to leave the relationship, I'm going to leave you without money, I'm going to do whatever it is if you don't do what I want in this situation. So in terms of, you know, drivers and things like that, this is the Our Watch framework about gender drivers of violence against women more broadly. And, you know, a lot of this stuff is also relevant to reproductive coercion and abuse. Like, yes, you know, gender inequity is also relevant here. There are issues around that. And men's control of decision making, and extending that not just to where they can go, who they can see, what they can wear, and so forth, but actually taking that a step further of like control over what they do with their body and their reproductive organs. So it really is kind of the extreme end of that. Rigid gender stereotypes and so forth are also relevant. There's a lot of stereotypes in society about motherhood and women as mothers, and the appropriateness of motherhood, and how you should react if you get pregnant, and those kind of things, all relevant. And yeah, definitely masculinity and problematic masculinity. And I've seen this a lot with my work in intimate partner sexual violence as well, that women perceived that their partners were trying to sort of boost their masculinity by perpetrating sexual violence and that kind of stuff, and that there was a fragile masculinity there that needed to be sort of overcome. So all of that is relevant, but more specifically, this diagram here, and I apologize if some of that font is a bit small, but I'll read out some of the things. So this diagram comes out of that paper that I flagged earlier, and it's looking at where reproductive coercion and abuse sits in a sort of broader framework of violence against women. So you can see there, it intersects with intimate partner violence, with sexual violence, and with family violence when it's perpetrated by other family members. And it sort of sits across all those things. But then there's a lot of other factors externally that can either contribute and facilitate the reproductive coercion and abuse, or be protective of it. And so that's where I see a lot of stuff like government policies, around abortion access, and structural inequities that stop somebody from accessing services that are helping with reproductive autonomy. Certainly like the work that I've done with practitioners who were responding to migrant and refugee women, talked a lot about how things like visas and eligibility for certain services, Medicare and so forth, those kind of things were definitely facilitating reproductive coercion and abuse for those women. Even things like attitudes towards abortion, towards mothering, towards women's role in society, all of those kind of things, patriarchal norms around sex and reproduction, even lack of community knowledge and practitioner knowledge about reproductive coercion and abuse can be a facilitator, because people don't speak about this issue very much. It's a bit like sexual violence in that way, in the context of intimate partner relationships. People are more comfortable now talking about physical, even talking about psychological and coercive control, but things that are around sex and reproduction still, there's massive taboos about speaking about these issues. Women who will disclose physical violence might not speak at all about sexual violence or reproductive coercion. And if practitioners are not inquiring about this, then it just never gets talked about. So all those sorts of things I think are contributing to the mix. And, in terms of protective factors, it's basically the opposite of those. Strong policies around abortion access and so forth, and equitable access to services and good community knowledge can be protective. So the way I see reproductive coercion and abuse in light of that diagram is that it gets talked about a lot as a form of intimate partner violence, but I'm not sure that it actually is a form of intimate partner violence in itself. I sort of see it as intimate partner or family or sexual violence are the mechanisms to perpetrate reproductive coercion and abuse. So it's sort of harnessing those abusive behaviours for a reproductive outcome. And I've got a little diagram here which sort of illustrates that visually, which might be a bit clearer. But you have, the intent to promote or prevent pregnancy, the type of violence that's being used, and then the perpetrator. So to me, I think, it's not that it's a different type of violence, it's a different vehicle or different purpose for the use of that violence. Now, I'm going to share some hot off the press research here, so please don't share or tweet these slides or whatever, because this is not published yet. But I'm just going to share a little bit of qualitative work from from a study that's funded by the Oak Foundation and is looking broadly at psychological abuse and also reproductive coercion and abuse as part of that and how it intersects. So I've been doing in-depth qualitative interviews with 30 victim survivors and exploring, their lived experiences and impacts of reproductive coercion and abuse on mothering. And also we've been talking a lot about the motivation of perpetrators, because this is something that isn't really, there's not any real research on this. And so I've been speaking with them about what they think the motivation of the perpetrator was and why is this happening? Why are they trying to get you pregnant? Why are they trying to stop you from being pregnant? And it's been fascinating. And so in terms of what I think are some of the red flags based on the voices of these victim survivors, it's a bit different to what's in the literature so far, which is, building on a lot of stuff that's come out of the States and a very different context. And as I said, problems with how reproductive coercion is being measured. But what the survivors are telling me is that for a lot of them, they were in a situation of what I'm terming contraceptive vulnerability. So for a lot of them, there were reasons why they weren't able or weren't willing to use woman-led methods of contraception. So they either had, really bad reactions to the pill and they couldn't take that, or they, had bad experiences with an IUD or something like that and didn't want to use that method. So they were often in a situation where the only methods available to them were things like condoms or, the pull-out method. And of course, those methods are very, very vulnerable to manipulation and sabotage. And so they were often in a situation where this happened. And yeah, it was a real problem for them because they weren't in charge of their contraception. And for some of them, they weren't allowed to be as well. It wasn't just that they wouldn't have liked to be. Some people couldn't because the partner wasn't letting them. Some people couldn't because of medical issues. But the end result was that they were in this position where the protection available to them was pretty bad. And then, of course, combining that with relationships where they had very little sexual autonomy, they weren't allowed to choose when, how often they were having sex, if they had sex, that was not something that was within their control. So, they're dealing with dodgy contraception that's easily sabotaged. They're forced to have sex whenever the partner wants them to. It's a recipe for disaster, really. Often they were either isolated from their support networks or they never had good support networks in the first place. So there weren't people around them who they were able to talk to and kind of, find out whether this is normal or, what's happening here. And most of them were in relationships where there was a lot of other controlling behavior around, everything really. I also found for a lot of them, not all, but a lot, there was a pretty big age gap in the relationship. And I found that as well in my research with intimate partner sexual violence, that often the perpetrator is a lot older and there's this power dynamic that's set up where, by virtue of age and seniority, the perpetrator gets to sort of dictate what happens in the relationship. And yeah, that was something that a lot of them spoke about.
I loved that you brought it back to the gender drivers. I think that, it's amazing that you're contributing to the evidence on this. I just want to quickly throw to Desiree Larap. She's a public health nurse and an MRC PhD scholar at La Trobe University, the Judith Lumley Centre, School of Nursing and Midwifery. She's a clinically accredited in sexual and reproductive health and a PhD student of SPHERE, the NHMRC Centre of Research Excellence in Sexual Reproductive Health for Women and Primary Care. Thank you so much, Desiree.
Can we kick off to somebody else real quick and then we can swing back to me? I'm sorry, I don't know why I'm clicking on the buttons and it's not working.
Sure.
Not a problem at all. Helen, are you available to present? I'll throw to you if that's
Hello.
okay.
Thank you.
Back to Desiree.
Yes, thank you,
Helen.
Laura, and welcome to everyone. I'd just like to check, Laura, are you happy to operate the slides?
I can.
On my behalf. I'm hoping that they will be visible, and I'm hoping that I'm visible too, along with our WDV background. And I'm aware that there are other speakers, so I'll try and condense this quite a bit. So my name is Helen Freris. I'm from Women with Disabilities Victoria, and I'm the Health Services Program Manager at WDV. I'd like to begin by respectfully acknowledging the people of the Greater Kulin Nation, and we're on slide 2, the traditional custodians of the lands and the waters on which we're gathered. And I'd like to pay respects to elders, past and present, and those who will come after. And welcome to elders from any communities who are here. I acknowledge that the land we're meeting on today is sovereign land that's never been ceded. So we'll move on to the next slide. So in terms of the presentation, I'm going to talk about reproductive coercion as it's related to the experiences of women with disabilities. And there are some strands that are common to those that Laura described, and some quite different strands. So, and I'm aware too of the inadequacy of definitions. But first of all, disability. WDV works under a model where people self-identify as living with disability, so physical, sensory or intellectual, cognitive, acquired brain injury, autism spectrum, neurodiverse, chronic illness, etc. So reproductive coercion, the way that we think about it, is multiple definitions, of course, but the systemic issues, I guess, are forefront to us that perpetuate violence and against women. So disempowering language and also disempowering acts. All right, so next one, slide 4. And I'm stumbling a bit so because I'm cutting bits out as I go. All right. So sexual and reproductive healthcare rights for women with disabilities. There's a context to this, which is the Convention on the Rights of Persons with Disabilities, UN, access to information and services, living free from violence and coercion, which is the key word here, and privacy, spaces and personal information. Eliminate discrimination against persons with disabilities in all matters relating to marriage, family, parenthood and relationships, including in the areas of family planning, fertility and family life. And of course, equal access to sexual and reproductive health programs in the community. So I guess that's the basis on which we frame the work we do around sexual and reproductive health and coercion. And the context to all of that is in the legislation, the UN legislation that I've just spoken about. So we're on to slide 5. We have observed a very strong link between what is defined as reproductive coercion and violence against women with disabilities. Reproductive coercion is using power and control deliberately to limit women's choices when it comes to reproduction, contraception and abortion. Women with disabilities experience the same kinds of reproductive coercion from their intimate partners as women without disabilities, as we've talked about before in Laura's presentation. And there are some additional experiences of ableism at play here too. Disability discrimination, based coercion and violence. So perpetrators use disability against women with disabilities to silence and control. Violence is more intense, occurs over a longer period of time and often from multiple perpetrators. And of course, that can be individual perpetrators or systems. And that's a key point in the presentation. If we move to the next slide, a significant point for us when we think about reproductive coercion is eugenics, which is as historically, sterilisation was driven by eugenic ideas of fitness, which are still held widely in society today, subtly and perhaps not so subtly, around disability and the desirability of disability within children. So it was sought to sterilise or remove children from anyone with quote unquote undesirable traits, including people with disabilities or perceived disabilities. And the disability was very much perceived by the system doing the sterilising, not the person themselves. And it was aimed to prevent disabled children from being born ultimately. And whether those children were to parents with disabilities or to with or without. Today, these ideas are seen in the stereotypes and negative ideas around sex, disability, and women with disabilities. So an intersectional view of what is and isn't appropriate for women with disabilities. If we move to the next slide, and just rushing through. Okay. So for women with disabilities, reproductive coercion can also look like forced or coerced abortion, forced or coerced sterilisation. And the key word here is forced or coerced. So there may not be physical force or physical violence involved, but very strong techniques of coercion used. Again, by individual perpetrators and by systems. So another form is excessive use of long-active reversible contraception and disregard for consent and decision-making of women with disabilities, and the lack of acknowledgement of informed consent that is possible. All right, so speeding through to slide 8. Forced or coerced abortion, similar experiences to non-disabled women around coercion from outside, but motivated by prejudice in the form of ableism. Women with disabilities have the additional excessive scrutiny of parenting ability, and I've put that in quotes because there are certain perceptions of what how parents should be, and a higher level of scrutiny of that on the parenting of women with disabilities. Parents, families and carers worried about the impact a child will have on them, as opposed to the woman necessarily. Involuntary or coerced sterilisation of people with disabilities. There was actually a Senate report on this in 2013. So it's still quite a prevalent issue. And there's a quote from a disabled activist, Nicole Lee: "As a disabled woman to the outside world, my choice to end a pregnancy was seen unquestionably as the right decision. This view potentially stems from the fears around passing on genetic disorders. It's a fear that has its origins deeply rooted in eugenics and what is subjectively deemed as whether or not a disabled person can live, quote, a good life. Or it could come from the unwitting negative views that surround our body's ability to adapt or cope with parenthood." From Nicole Lee. All right, so forced sterilisation without informed consent is against human rights, as we've seen with the legislation, restricted but not illegal in Australia, and a form of violence and control of women with disabilities, often targeted at women with intellectual disabilities, and misguided attempt to manage menstruation and to prevent pregnancy in cases of sexual violence, and make sexual violence invisible, actually. Which is a real problem. Historically, it was hidden, and today women are often taken overseas by family members, or they find a specialist who will hide the true nature of a reason for a surgery. We'll move to the next one. All right, long-acting reversible contraceptives stay in the body, as we know, for an extended period of time, and of course they are really valuable in many instances, but they are coercive if women aren't offered informed consent as to what is happening, why they're being used, and not given the support to make choices. Okay, next slide. So consent and decision making, just thinking about pacing things towards the pace of women with disabilities, and I guess consent and decision making supported and informed, and respect for bodily autonomy and dignity of risk, assumption of competency to consent, and that's a key issue for us, that most, the majority of women with disabilities can and will make informed choices if they're supported appropriately. And it's the individual who makes the decision and has the right to make decisions for themselves. Just going to rush through to the next bit. This is sounding quite garbled. Apologies.
Not at all, Helen.
All right. So I guess the some key points around practice and policy. And just, I guess the first one is stop dismissing violence against women with disabilities as a major point, and recognising that these practices are a form of violence and abuse. Acknowledging internalised ableism and dismantling those ideas within, individuals, but also within systems. Educating teams, workplaces, and thinking about the human rights approach to guide the work of policy and practice in sexual and reproductive health. So these are ways, I guess, of eliminating reproductive coercion and really thinking about the attitudes that are perpetrated by the systems that that we work with, eliminating sexism, gender-based violence, of course, and working with a trauma-informed approach with individuals, building an accessibility, disability inclusion from the beginning, and bringing that into policies, acknowledging that women with disabilities have experience and are experts in their own lives and can and will, with the appropriate support, make informed decisions. So that's the last point, I think. Thank you very much for your attention. Very happy to take some questions and discuss anything further.
Thank you so much, Helen. We might do questions at the end if we've got enough time. And we definitely will. No, apologies. So this is the pitfalls of doing lunchtime seminars, but we will definitely record this, and we'll head to Desiree at the end, and if anybody needs to go, everybody will be receiving a recording. So just to quickly go to Rosie Ariel-Lees, sorry, apologies if I've got that wrong. Rosie has several years experience in women's health sector, including in workplace gender equality and prevention of violence against women. She's the acting team leader of the Research Advocacy and Policy team at the Multicultural Centre for Women's Health, and the RAP team, as they're called, are currently working on the multiple projects considering the intersections of sexual reproductive health and mental health. Over to you, Rosie. You're on mute, sorry.
Sorry about that. Is that better?
Much better.
Yep. Great. Okay, thank you. Okay, so I'd also like to start by acknowledging the traditional owners of the land on which I'm zooming from, who are the people of the Kulin Nations. So as Danny said, I work for the Multicultural Centre for Women's Health. We are a national migrant women's health organisation. We've been advocating on migrant women's issues for over 40 years now, and we are very much an organisation that is run by and for migrant and refugee women. So today I'm going to be talking about taking an intersectional and systemic approach to reproductive coercion and abuse, and I'll be drawing on our advocacy work and our involvement in some research projects. And I'll be framing these issues at the levels of systems and structures. So we really strongly advocate at WH that in order to promote reproductive justice within migrant and refugee communities, it's important to frame reproductive justice through an intersectional approach that considers issues of safety, coercion, and abuse at the interpersonal, institutional, and structural levels. So we consider all those levels. And I'm really thankful to both Laura and Helen, who have discussed definitions of reproductive coercion, so I won't go through them myself, but instead I'm going to be focusing more on the context. So in like what's the context in which we name certain phenomena as reproductive coercion and abuse. And Laura, you also touched on this, like do we only say located at the level of the interpersonal? Do we also locate it at the institutional and systemic levels, and what are kind of the advantages of framing it in that way? And at MCWH, we certainly think for advocacy reasons, it is advantageous to frame the issue at a systemic level. So when we're talking about migrant women and coercion, it's important to understand the broader historical context and the coercive factors involved in Australia's migration regime. So up on the screen, I've got some distinct policy periods in the migration regime. I'm like a kind of simplified schema. It's definitely more nuanced than that. But what I'm trying to capture here is state attempts to essentially control the racial makeup of the nation and how those attempts are reflected in the migration policy. Because racism at the national level is tied, it's always been tied to fears of miscegenation, and the proportion of the population who are considered to be white. Race and reproduction are closely interlocked. So this idea that you control race by controlling immigration and reproduction. And there's been a lot of literature done on the history of the White Australia policy, for instance, and how it's been tied to the eugenics movement. And Helen's also spoken about eugenics and how it's used still very deliberately to reproduce and maintain ableist privilege in quite direct ways. And in the current kind of era of migration, we might not have such direct policies, but since the 1990s, we've seen a massive increase in the proportion of people in Australia who are on temporary visas. So being on a temporary visa means you have lots of limitations on your visa entitlements and access to Medicare, and that this really impacts reproductive autonomy as well as other personal forms of autonomy. So I guess what we'd argue, like when we come to the question of do we consider all these structural and systemic kind of drivers as factors or coercive mechanisms or as abuse in themselves, we'd say when we really place migrant women's experiences at the centre of our thinking, we do frame them as coercive mechanisms that can enable and facilitate abuse. And I guess, exactly, I'm not sure that exactly what we label it and how we define it, whether that matters, as long as in our approach, we understand that these that there are structural and systemic mechanisms that enable abuse, and therefore we can't promote reproductive justice if we just focus on the interpersonal level. We have to look at the level of systems and aim for transformative change at that level. Which brings me to our model of promoting reproductive autonomy, which is very much about promoting gender and racial equality, and I think fits in quite nicely with what Helen just presented before. So I'm very happy to share these slides if anyone would like them afterwards. Now, the case study, Laura from WHISE, you said that I'll be talking about international students. I'm actually going to talk about another case study, which is more recent. And this case study, Laura at Melbourne Uni, this is based on your research and your team of researchers. So now I feel a bit nervous. Hope I can do justice to your research. When we think about coercive mechanisms, what we really want to think about are how are personal decision-making and bodily autonomy restricted by government policies, institutions, systems, and structures. So the list I've got up on the screen, it's often a list that we apply to our analysis of Australia's immigration system. But we can also apply this to our health system and the interpersonal interactions that are conducted within it. And kind of look at these through the lens of like, how are these coercive mechanisms that limit migrant women's reproductive autonomy and which place them at increased risk of coercion at all levels. So the example I want to draw from Laura, Tarzia, your research and your research team's work is the research you did finding that the inability of health professionals and police to communicate with women who have low or no English proficiency, this not only negatively impacted victim survivors' ability to access support, but facilitated the perpetration of reproductive coercion and abuse. And so this research happened in two main contexts, with health providers and with police encounters. And what the researchers found was that if the doctor or the police person thought that their own understanding of the woman was good enough, then they wouldn't call an interpreter. So it was about whether the understanding of the woman was good enough for the service provider, and there wasn't this kind of understanding that it's the woman's call or decision whether to have an interpreter there. Now, what this does is it created a void in which the perpetrators could then step in, speak on the person's behalf, and then take control of the information and ultimately take control of reproductive decisions. So, for instance, there were examples of where even if a woman spoke fluent English, husband would accompany her to all doctor's appointment, claiming that he had to be there to interpret. Husband asked a physician to perform a hysterectomy without the patient knowing, meaning she couldn't have children afterwards. Another patient was prescribed contraceptive pills, thinking they were vitamins. And these are all examples of doctors listening to the patients, failing to listen to the patients, and instead trusting the perpetrators, basically because they, for whatever reason, didn't engage an interpreter. And in this way, they really enabled reproductive coercion and abuse. Now, in police interviews, this is a huge issue because when police interview the perpetrator with better English and they use the perpetrator as an interpreter to interview the victim's statement is obviously compromised and the victim can be misidentified as the perpetrator. So there are really big issues here. And the lens I kind of want to bring into it is, Australia always has, and I think always will be, a very multilingual country, but really we can see like the dominance of monolingualism and the use of English here, and how that monolingualism and that privilege of using English has been institutionalized historically. This has clear roots in colonialism, has clear roots in the White Australia policy, which used language like that policy tested migrants on their knowledge of European languages. So it used language as a proxy for race to kind of maintain whiteness. So I guess that's kind of what I like, the added perspective that I wanted to draw out of that case study is, how do we think about the systemic and historic factors that perpetuate sexual and reproductive abuse and coercion. And I think similar to what Helen presented, so we really advocate for promoting reproductive justice and health. We advocate for practices that are systemically and historically transformative, and also quite deeply reflective. So again, I know we're quite tight on time, but I'm happy to share these slides and talk to anybody afterwards. Thank you, everyone.
Thank you so much, Rosie. Really appreciate it. And yeah, apologies for rushing everybody through this such interesting topics. And I think, yeah, more discussion is definitely needed. We might go back to Desiree if you're able to share your slides this time. Hey, look at that, perfect. And we'll definitely share the slides and the recording at the end. Desiree, are you off mute?
Yes, I wanted to just make a joke and promise that I'm a millennial and I know how to work a computer. Anyways, thanks so much for the introduction, and I'm sorry about the technical issues. I guess I'm a bad millennial. In any case, so I've been asked to talk about different forms of reproductive rights abuses beyond the individual and interpersonal level. So that's been covered beautifully as well by others, and intersectionalism or intersectional feminist, applying an intersectional feminist lens. And that has been really well described by the other presenters. So I'll kind of focus more on the tools that we have for screening for reproductive coercion and abuse, and also some of the resources that are kind of currently available. So just, we've been talking about some difficult things, and many people here might have some of these experiences or know somebody who does. So just a reminder about the resources that are available. And we hope that people have trusted folks that they can talk to in their life about some of these things. So Rosie has talked about the term intersectionality, but I just wanted to give credit to the person who coined this term, which is Dr. Kimberly Crenshaw in the United States, who first used this term to talk about the experience of Black or African-American women in the United States, and really recognizing the interplay between not just gender discrimination and sexism, but also the experience of racism. And that as we've kind of moved forward over time, that has been expanded out to the many forms of, unfortunately, discrimination that exist within our societies, which have been spoken about. We've also talked about that this isn't necessarily a binary issue. And unfortunately, a lot of the research that we have does kind of focus on a really heterosexual and dominant culture worldview. And that means that the research that we have, in a way, is contributing to a health equity gap, not just for LGBTQ individuals, but also migrant and refugee women and other people of color. And so unfortunately, the information that we have is kind of limited to the data that's available. And we're hoping that through our ongoing work, we can look to change some of this. So these terms have kind of already been spoken about. And I think I just wanted to highlight that, I guess, as a nurse and as a researcher, while some of these things are quite important around terminology for research, because it means we can be very specific and attribute cause and all of these types of things that we put in papers that hopefully lead to some really powerful advocacy pieces for people in practice, that really broadly what we're talking about are abuses of sexual and reproductive health and rights. And so it might be less helpful to kind of think about all the nitpicky terminology if you're working in practice, but more kind of the different issues that have been spoken about that clients or patients may present to you with, and ways that you can support them. So this is the work already that Laura has talked about. And then on the right, we just have some other work that's come from the United States. It's a bit older now and came from a literature review. And again, Laura's talked about the challenges with the literature, but looks at how both experiences of race through racism or ethnicity, but also as identity can affect how people experience reproductive rights abuses, not just reproductive coercion, but also unintended pregnancy and intimate partner or domestic and family violence. And this is the way that Dr. Sharvon Holliday kind of presented this work, and other speakers have kind of talked about this kind of broad interplay of reproductive rights abuses across a continuum that we sometimes speak about as the socio-ecological model. And I just wanted to focus on some of the things there that are around the individual level. So reproductive, or age is mentioned, so that's reproductive years, gender being female, substance use, particularly by partners, alcohol and other drug use, access to education and employment, self-esteem, mental health, and fear in relationships. And so again, as Laura mentioned, there are challenges with the literature and the research that we have. And so some of these things we might think of as potential risk factors for reproductive coercion and abuse, although we can't really confidently say that. But either way, we know that in some cases, people who are experiencing reproductive coercion and abuse may be experiencing broader forms of domestic and family violence, and also the opposite of that as well. So if you have a disclosure from someone either about reproductive coercion and abuse, it can provide an opportunity to think about sensitive inquiry around those other broader domestic and family violence issues and ways that people can be offered support. As well, again, if somebody is presenting or you're providing support services around domestic and family violence, whether to inquire if it's appropriate, thinking as well about the impact on sexual and reproductive health, and linking clients to services if they wish and if that's appropriate. So this is just a table with a lot of information that a lot has been kind of talked about by the other presenters, but it's really not about the detail, more to just show that we have a big discrepancy in what we know about who, and that really a lot of assumptions have been made, I think, from my perspective, and a lot of the research that we have on reproductive coercion and abuse that's come from high-income countries or quote-unquote Western countries like Australia has mostly focused on the role of the partner. And so in our context, we know, besides some of the work that Laura is doing together with other colleagues, we know very little in our context about the role that family or in-laws or others could play. And there's also been an interesting way in which mainly looking at the experience of being forced into pregnancy has been explored versus other communities, like have been spoken about, women with disabilities, where we've also looked at sterilization, but not necessarily looking at all of the things all together for everyone. And so we just have a really large gap in our knowledge. And I think it also just speaks to assumptions that we live in a very heterogeneous, or a very homogeneous society by a lot of the people that have necessarily been leading the research. So it's great to see more work being done in this space. So as far as measurement goes, these are the two most widely available measures. One is the reproductive coercion scale, and the other is the reproductive autonomy scale. And like Laura touched on, neither of them talk about abortion coercion. And so these tools really have led, at least for the survey research and the quantitative research, what we know about reproductive and coercion and abuse. So maybe just when we're looking to the literature and thinking about using it for advocacy pieces or for policy, just being mindful about kind of what sits underneath that data. And like Laura mentioned, there are questions within the reproductive coercion scale that really focus on stealthing. And you only need to answer yes to one of these questions to be kind of ticked as experiencing reproductive coercion. And so that means that a lot of the data we have has included people who may not have experienced reproductive coercion abuse if it hasn't had any intent or even led to any kind of pregnancy or reproductive related outcomes. But also that we haven't captured a lot of people because we don't have any of that information about those people that are experiencing coerced sterilizations or coerced abortions. This is just to tell you that there is a national survey that's ongoing here in Australia, and hopefully within the next year or two, we'll have some better data about the topic of reproductive coercion abuse within the context of Australia. And this might be interesting to some that are kind of looking at those institutional level issues or systemic issues. There's a new scale that's come out on contraceptive agency. And while it's focused on healthcare providers and the interaction that they have with their patients, it does look at coercive behaviors and non-judgmental care. And some of these questions around coercive care, perhaps some of the language could be changed to ask directly as well about partners. In practice, mostly we're not getting, most people are not screening, but just to let you know that there are some available screening questions. This is by Children by Choice, and I'm not endorsing necessarily any of these screening questions, but just to let you know what's out there if you're looking for things for your service, as well as an example of something that's being used more broadly in obstetric care in the United States. I'm trying to get down to one question to ask in a short interaction in a clinical setting, which can be a challenge, but this is their best bet at doing it. Just to say that we are working to develop a scale that's more accurate here for Australia. So if you feel that you have expertise in this area, please reach out to us if you'd like to be involved. And to let you know that we have a consensus statement through the Center for Research Excellence that I'm attached to Sphere. If you'd like to look at our recommendations, the link is there, as well as some resources and referral options for your clients if you're a service provider or interested in additional training, and I'm happy to share these slides. So thank you.
Desiree, thank you so much for that informative presentation while doing that against the clock. And we do apologise to both our presenters and the attendees for the issues of time. Clearly, this is an issue that requires more extensive examination and discussion, and there's a lot of interest in this. As said, we will circulate the recording to all registrants and attendees today. And I would like to most sincerely thank not only our attendees, but of course our brilliant presenters today, Laura, Helen, Desiree, and Rosie, for their excellent contributions, not only to today's webinar, but to furnishing our understanding of reproductive coercion and abuse in research and practice more broadly. Just before we conclude, I would encourage attendees to use their phones to scan the QR code on the screen. It will take you to a very brief SurveyMonkey survey, which enables us to continue to provide informative events for practitioners and community in the Southern Metropolitan region. This data is absolutely invaluable to us. So we sincerely appreciate you taking a few moments of your time to complete the survey. And on behalf of Women's Health in the Southeast, I'd like to once again thank our presenters and our attendees for joining us today. This concludes our webinar. Thank you.